Chapter 2 is going to look at cholinergic pharmacology. In this figure, we're going to look at the synthesis and release of acetylcholine. We'll talk about what happens to acetylcholine once it is released, and then we'll talk about several drugs that have an impact on this type of pathway. But of course, when you look at the figure, it's not intuitive as to where this figure would be found in the body. All I see is a cholinergic nerve. And notice on the postsynaptic side, it simply says effector cell. So I don't even know what type of organ I'm dealing with here. Is the effector cell, is it a ganglia? Is that another neuron, for example? Or is that an organ itself? I'm not sure. Let me tell you what I would do in this situation, is I would draw myself a diagram. Your pictures, when you draw them yourself, they don't have to be the prettiest thing in the world. They just need to be functional. So what I've drawn you is kind of a stick figure version of the autonomic nervous system. Can you identify the parts that I've drawn here? Notice the first pathway has a long preganglionic fiber and a short postganglionic fiber. The second pathway, short preganglionic but long postganglionic. So the first one is parasympathetic, the second one would be a sympathetic pathway. The third pathway, pretty easy to identify, that is innervation of the adrenal medulla. It actually says adrenal, that helps too. And the fourth pathway, it kind of looks like a single nerve innervating bacon. Bacon, yummy. Actually, that's skeletal muscle. That would be your neuromuscular junction. That would be a somatic motor nerve, a single neuron innervating skeletal muscle. But what do all those nerves that I've starred have in common? All of those nerves are cholinergic. All of those starred nerves are releasing acetylcholine. So this generic diagram in our book could actually be depicting any of those nerves in this diagram on the right. They're all cholinergic after all. So what if I did some quizzing with you? If I start with that first pathway, that first neuron is a preganglionic nerve, and if it releases acetylcholine, what receptor would it activate on the postsynaptic side? Well, since that's the ganglia, the receptor would be N sub N. Correct. Now look at that same pathway, the one on the far left. What if it's the second neuron? What if my picture in the book is depicting that second neuron in that parasympathetic pathway, and the organ that's being innervated happened to be the heart? So if that postganglionic nerve releases acetylcholine, what receptor would be found on the postsynaptic side on the heart? Well, for parasympathetics, that would be muscarinic M2, correct. One more. What if the nerve on the far right, that somatic motor nerve, was the nerve in our book here? If it releases acetylcholine, what's the receptor that gets activated on the postsynaptic side? It's another way of saying, what's the receptor on skeletal muscle? That, of course, would be N sub N. N sub M receptors. When I take a look at this diagram, I want to constantly remember neurotransmitters and, of course, receptors. All right, let's discuss this figure. In order to make acetylcholine, we have to have the uptake of choline. Folks, that is the rate-limiting step in the synthesis of acetylcholine. In order to synthesize acetylcholine, start with the uptake of choline. Choline combines with acetyl-CoA. The enzyme there is called choline acetyltransferase. That's going to form acetylcholine, which gets stored inside storage vesicles. This is what we do with neurotransmitters. We store them in storage vesicles until it's time for them to be released. Do you remember the process for releasing the neurotransmitter? First, the membrane has to depolarize. When the membrane depolarizes, calcium channels open, we have calcium influx into the neuron, and the vesicle will now migrate to the membrane, releasing the transmitter. It's what we call calcium-mediated vesicle fusion. That's very important to remember. Once acetylcholine is released into the synapse, several things can happen to it. Let's discuss those. One of the things that can happen to acetylcholine, the thing that we hope happens, is enough acetylcholine diffuses across the synapse to activate the postsynaptic receptor. Since we don't exactly know from this diagram what organ is on the other side, we don't know if we're activating muscarinic or nicotinic receptors in this picture, but you would if you had a real neuron in the body. You would know that you're at the ganglia and you're activating a nicotinic receptor there, or if it's perhaps an organ innervated by the parasympathetic nervous system that contains muscarinic receptors. So one thing that happens, activation of postsynaptic receptors. A second thing that happens, acetylcholine is metabolized by acetylcholinesterase. Make a note, this is the major pathway for removal of acetylcholine from the synapse, metabolism by acetylcholinesterase. It's the answer to the question, why does acetylcholine have a short half-life? When it's metabolized by acetylcholinesterase, acetylcholine gets converted into choline and acetate. Interestingly enough, the choline is recycled by this neuron. A third thing that can happen to acetylcholine that's released into the synapse, some of that acetylcholine can diffuse back and bind to a presynaptic autoreceptor. Autoreceptors are almost always going to be GI-coupled receptors. In this case, most often we're going to find a muscarinic M2 receptor serving as an autoreceptor. The purpose of that autoreceptor is a negative feedback. I need a way to decrease the release of my transmitter. I need a way to control this nerve releasing acetylcholine. So when acetylcholine goes back to the autoreceptor, stimulates M2 receptors, M2s are GI coupled, I see a decrease in cyclic AMP. What that leads to is closing of calcium channels. When I close calcium channels on the membrane, I stop calcium influx, therefore I stop the release of the neurotransmitter. Autoreceptors are a very common thing for nerves. Again, that's the way to control the release of your neurotransmitter. We have several drugs that can interact with this pathway. The first one, labeled as number 1 on this diagram, is the drug hemicolinium. This is not a drug that's used clinically. Rather, it's used in the laboratory because it can block the uptake of choline and therefore decrease the synthesis of acetylcholine. Because it's not clinically used, there's a lower chance that you would ever see this drug on your step 1 exam. But it's totally different for number 2. Botulinum toxin blocks the release of acetylcholine, and this mechanism is very important for you to understand for your step 1 exam. The organism that produces this toxin, Clostridium botulinum, Botox can get inside this neuron, interacts with a molecule called synaptobrevin, preventing the vesicles from migrating to the membrane, thereby blocking the release of acetylcholine. And if you think about the therapeutic uses of Botox, if you were to inject Botox over here on the diagram at the neuromuscular junction, I'm going to inhibit the release of acetylcholine from that somatic motor nerve. So you might think of cosmetic purposes. You want to get rid of those wrinkles? Botox could be used for that purpose. It's going to relax the skeletal muscle. If you have someone with acute muscle spasms, acute dystonias, Botox can be used for that. If you have someone with hyperactive sweat glands, they sweat too much, you can inject them locally with Botox. Again, local administration of this drug, obviously you would never want to give this drug systemically because of its ability to inhibit acetylcholine in lots of sites. Another type of drug that's very, very important clinically, acetylcholinesterase inhibitors. Those are drugs that block acetylcholinesterase and therefore increase the half-life of acetylcholine. But let's make a note about that type of drug. The only time an acetylcholinesterase inhibitor is going to work is at an innervated organ. After all, you can't increase the half-life of acetylcholine if you don't have a nerve releasing acetylcholine. There's 2 thoughts for your exam that I have here. One is sometimes the exam will do what's called a denervation experiment, where you remove the nerve. If you do a denervation experiment, if I remove the cholinergic nerve, I've removed the ability for an acetylcholinesterase inhibitor to have any effect because I don't have a source of acetylcholine for that type of drug to have an influence on. Another thought would be, what if I had cholinergic receptors in the body that were not innervated? This is something that we're going to see a little bit later on. This is a real story. We have muscarinic receptors in the body that are not innervated. Clearly, at that type of receptor, acetylcholinesterase inhibitors would have no effect. Let's summarize what we've discussed so far for cholinergic receptors. In fact, let's draw a flowchart. When you think about cholinergic receptors, they come in two subtypes. That, of course, would be nicotinic and muscarinic. But you already know that there are two types of nicotinic receptors. That would be N sub N and N sub M. But of course, there are three major types of muscarinic receptors: M1, M2, and M3. In fact, there are M4 and M5 receptors, but we don't know as much about those as we do the other three. Let's go to nicotinic receptors for a second. When it comes to nicotinic receptors, can you identify an agonist besides acetylcholine for nicotinic receptors? You don't have to think too hard on this one. That, of course, could be nicotine. Nicotine can stimulate nicotinic receptors after all. But what about an antagonist specific for N sub N receptors? Ask yourself this question: where's that receptor found? N sub N receptors are found on the ganglia, so what would you call that type of drug that blocks that receptor? That's right, ganglionic blockers. What do we call the drugs that block N sub M receptors? Again, where is the receptor found? It's found at the neuromuscular junction, so we call that group of drugs neuromuscular blockers. So we've got some selectivity for antagonistic nicotinic receptors. Now let's compare with the muscarinic receptors. Obviously, we have a number of drugs that are muscarinic agonists, and those drugs stimulate all muscarinic receptors. And it turns out that if you use a muscarinic antagonist, muscarinic blockers block all muscarinic receptors. We have tried to develop some selective muscarinic blockers, but the ones that we have clinically available now pretty much block all muscarinic receptors. This table looks at all the different types of muscarinic receptors and where they're found in the body. Remember, we've discussed M1, M2, and M3. And as I consider all of the different organs in the body, we can come up with some basic rules as to where these receptors are actually located. For example, the major muscarinic receptor in the CNS is M1. M2 receptors, we've already seen, are found on the heart, and M3, of course, is the major receptor found in the periphery, found on various other organs. So an easy way to remember, if I said, what is the most important organ in the body? I think a lot of people would agree that the brain is the most important organ in the body. So the number one organ has M1 receptors. What's the second most important organ in the body? All right, all you sensitive people, now it's time to say the heart. The heart has M2. It's the second most important organ. Now, who's the third most important organ in the body? It's interesting. Get all kinds of different answers here. Some of you love your liver. Some of you thinking, my large intestine, that's my favorite organ. Some of you are kidney people. But you know what? It's a tie. Everybody else is third. So if you have to pick an organ in the periphery and say, what's the muscarinic receptor? Chances are very high that that's going to be an M3. If you look at this table, mostly it's M3 receptors found on those various organs. So that's a way for you to remember where those receptors are found. Since this is a very important table, we look for ways to be able to digest such a large amount of information. Here's the good news. Remember the exercise that we did earlier, where we talked about the eye and the heart and the lungs and the GI tract and the urinary tract? The first 5 parts of this diagram we've already looked at. We've talked about the pupils constricting in response to muscarinic activation. You get bradycardia when you stimulate M2s on the heart. The lungs will bronchoconstrict. That's an M3 effect. GI and urinary motility are going to increase, and those are also M3 effects. So the first 5 parts of this table you should be very, very comfortable with. Let's go down to the sphincters. Sphincters have M3 receptors. Most of the time, you want to activate those M3s to relax, and that's so that you can continue to move things through the body. Think about your GI tract. You want to continue to move things in the GI tract or the urinary tract. But we do have an exception. an exception to the rule that sphincters are going to relax. The exception is the lower esophageal sphincter. It's actually going to constrict. And if you think about it, an advantage of that is that when you constrict the LES, you get a less of a chance of getting reflux of stomach contents into the esophagus. Of course, if you ever suffer from esophageal reflux disease, the major problem in that situation is the LES has over-relaxed. And some of you might remember some things that can relax the LES. They're actually some of the best things in life. Things like chocolate and coffee. And if you're like me and you like chocolate coffee, you're pretty much doomed because you're going to get a relaxation of the LES. But of course, as a pharmacologist, we know how to fight back. So I just use proton pump inhibitors, right? Because who's going to stop drinking chocolate coffee when you really like that? Next, we've got glands. Glands have M3 receptors, and they're going to cause secretion. That can be sweating, salivation, and lacrimation. Those are all M3-mediated effects. But watch out. Sweating is the only thing on this table that is a sympathetic effect. It's sympathetic, but remember, mediated by muscarinic receptors. I think actually the hardest part of this table, blood vessels. Blood vessels have muscarinic M3 receptors, and they can vasodilate through nitric oxide. Now here's the confusing part. Those M3 receptors on blood vessels are not innervated. They're the only receptors in this entire table that are not innervated. When I get to a situation like this where I'm sort of confused, really all of those other receptors are innervated, but M3s on blood vessels are not, this would be an excellent time for you to draw yourself a diagram. Draw yourself a little cartoon to illustrate what's going on with these receptors. Let's do that now. So here's my blood vessel. Blood vessels in the body have 3 autonomic receptors. Let's label those receptors as alpha 1, beta 2, and M3. You know what's nice about that? If you put the receptors in alphabetical order, alpha, beta, and then muscarinic, you've also put them in numerical order, 1, 2, and 3. That's kind of nice. Alphabetically and numerically, it matches up very nicely. If those are 3 receptors found on every blood vessel in the body, if I reminded you that only one of those 3 receptors is actually innervated by a nerve, the other 2 are not innervated. Which one of the 3 is innervated by nerves? And that would be alpha 1s. So let's add that to our picture. Alpha 1s are innervated. Norepinephrine released from those adrenergic nerves activates alpha 1s to vasoconstrict. So if I said, what receptor on your blood vessels contributes to blood pressure control on a moment-to-moment basis, you would have to say alpha 1. For example, if you're sitting down right now and then you stand up, it's activation of your alpha 1s that's going to vasoconstrict to increase TPR and blood pressure. Because beta 2s are not innervated. So moment-to-moment beta 2s are not really involved in blood pressure control. But how do you activate non-innervated beta 2 receptors? It's not through norepinephrine, because norepi is the transmitter from adrenergic nerves. Of course, you can activate beta 2s by epinephrine released from the adrenal medulla. Epi goes into the circulation, so let's add epi to our blood vessel. Epi in the circulation can activate those beta 2s to vasodilate. Now, of course, epi in the circulation can also activate alpha 1s. So we see how you activate alpha 1s. We see how to activate beta 2s. What about those M3s? Now, M3s are not innervated. So you have to ask yourself, do you have a circulating neurotransmitter that can activate M3 receptors? I mean, is acetylcholine circulating throughout your body right now? And the answer is no. We don't have a neurotransmitter physiologically that can activate M3s on blood vessels. So as a result, physiologically, this receptor is unimportant. Now you might be thinking, we just spent all of that time talking about an unimportant receptor. Well, I didn't say ever that this was a non-functional receptor, right? The table reminds us that if I can stimulate an M3, I'm going to get nitric oxide mediated vasodilation. but you don't have a physiologic activator of this receptor. But how about a pharmacologic activator? That's where it's relevant. If I give a drug that's a muscarinic agonist, and I take that drug systemically, a muscarinic agonist in the circulation is going to activate all muscarinic receptors, all of the ones listed in this table, and it will also activate M3s on blood vessels. That will cause vasodilation and a drop in blood pressure. Now, let's think about this. If I give a muscarinic agonist causing M3 vasodilation, what about the effects of a muscarinic agonist on the heart rate? Well, if I give a muscarinic agonist, I'm also going to see a decrease in the heart rate. However, is that decrease going to persist, given that I'm also at the same time stimulating M3s to vasodilate on the blood vessels? If I vasodilate and I drop the blood pressure, what should the autonomic nervous system do to the heart rate? That's right, cause a reflex tachycardia. So if I looked at an experiment where I'm giving a muscarinic agonist and I was plotting the effects of that drug on heart rate, the immediate effect of a muscarinic agonist on heart rate would be to decrease the heart rate because of M2 activation. But shortly after that decrease, I'm going to see a reflex increase in the heart rate, reflex tachycardia, caused by the drop in blood pressure from M3 vasodilation. That's an interesting experiment. Think about that. In fact, what if, prior to giving a muscarinic agonist, I pre-treated with a ganglion blocker? How does that influence that experiment? The ganglion blocker blocks reflexes, but not direct effects. So if I then gave a muscarinic agonist after I had pre-treated with a ganglion blocker, the heart rate would go down, and it would in fact stay down, because that is the direct effect. I'm preventing the reflex tachycardia from occurring. How about this scenario? What if I gave a person who's on no medication a muscarinic antagonist? The muscarinic blocker blocks all muscarinic receptors, including the M3s on blood vessels. Now, what happens when I block M3s on blood vessels? Your choices would be vasoconstriction, vasodilation, or nothing. Think about it. If I'm blocking a receptor that is not being activated, nothing is going to happen. Why does any antagonist work in the body? The reason an antagonist works is because it blocks the binding of an agonist. But in the case of the M3s on blood vessels, there is no agonist, so an antagonist has no effect. But if we modified that experiment, if first we administered a patient a muscarinic agonist, and we caused M3 vasodilation, and then we gave a muscarinic antagonist, now we can see an effect from that type of drug. If the muscarinic blocker has something to block, in other words, it's blocking the binding of that muscarinic agonist, I will see the vasodilation be reversed, in this case, by the muscarinic antagonist. It's an interesting case where I have to supply the agonist in order to see an effect of the antagonist. Here's a final thought. Since M3s on blood vessels are not innervated, acetylcholinesterase inhibitors will have no effect on these receptors because there's no source of acetylcholine. There's no synapse. There's no nerve releasing acetylcholine. You would expect that a muscarinic agonist and an acetylcholinesterase inhibitor to have the same type of effect in various organs listed in this table. One of the organs where you're going to see a difference between those two types of drugs, blood vessels. Muscarinic agonists vasodilate, acetylcholinesterase inhibitors, no effect. This table looks at our nicotinic receptors. We've already discussed these receptors and where they're found. N sub N receptors are found at the ganglia and the adrenal medulla, and N sub M receptors found at the neuromuscular junction. In the margin is a note, a bridge to physiology and anatomy, and what this note reminds us of is about the innervation of various organs. In fact, remember this is the rule. Most organs in the body are what we call dually innervated. They're innervated by both parasympathetic and sympathetic pathways. If you think about that, it's dual innervation. One of those two systems has to be the dominant system. So answer that question. What system typically dominates organs? Is it sympathetics or parasympathetics? Of course, the answer is parasympathetic. Parasympathetic pathways are the dominant pathways for most organs. In fact, if it's dually innervated, parasympathetics dominate. When is the only time that sympathetic nerves are going to be the dominant pathway? And the answer is when sympathetics are the only pathway that innervates that organ. It's what I call domination by default. If you're the only system, of course, you're the dominant system. Organs that are only innervated by sympathetic pathways: blood vessels and sweat glands. No parasympathetic innervation for blood vessels or sweat glands, so sympathetics are going to dominate those organs. All others, it's parasympathetic. This is the reason why, if you give somebody an acetylcholinesterase inhibitor and you raise the levels of acetylcholine, that means you're going to potentially activate all sympathetic and all parasympathetic pathways. So why is it that the effects of an acetylcholinesterase inhibitor look mostly parasympathetic? It's because parasympathetic is the dominant system for most organs. We've discussed different types of cholinergic receptors and their coupling mechanisms. This table summarizes that for us. M1s and M3s are GQ, M2s are GI. Now, nicotinic receptors, N sub N and N sub M. These don't use second messengers. These types of receptors are directly coupled to ion channels. They're coupled to the activation opening of sodium channels, causing sodium influx into the cell, and potassium channels causing potassium efflux. This table looks at our muscarinic agonists. Remember, all of the drugs covered in this table are non-selective at muscarinic receptors, which means they activate all muscarinic receptors, M1, M2, and M3. The first thing that I look at when I'm thinking about a list of drugs are easier ways to remember the names. When it comes to muscarinic agonists, think about the four letters CHOL. CHOL, found in acetylcholine, found in bethanechol, and found in methacholine. At least that helps me with the first three in this table. A little bit harder to remember drugs like pilocarpine and cevimeline, but those are also important drugs that are muscarinic agonists. Let's start with acetylcholine. Can you come up with two reasons why acetylcholine is not a very useful drug? Well, the first one should be pretty obvious: short half-life. Because it's rapidly metabolized by acetylcholinesterase, really it's too short to be of any real clinical benefit. The second reason maybe why you would not like acetylcholine as a drug is it's not selective for muscarinic receptors. In fact, it's going to activate all muscarinic and all nicotinic receptors. So a property of the other drugs in this table are this: they're all more muscarinic selective, and they all have a longer half-life compared to acetylcholine because they're more resistant to hydrolysis by acetylcholinesterase. Let's look at bethanechol. Bethanechol is an important drug that can be used to treat postoperative or neurogenic ileus and also patients with urinary retention. So if you have a patient who shows up and they have decreased GI activity or they have decreased GU activity, they can possibly benefit from bethanechol. It's a drug that stimulates bowels and bladder, and that's an easy way to remember. How about bethanechol for bowels and bladder? Of course, in order to use this drug, it has to be a non-obstructive ileus and a non-obstructive urinary retention. Then we've got the drug methacholine. This drug can be used as a diagnostic for bronchial hyperreactivity. This would be in a patient who has subclinical asthma. For example, you suspect that the patient has asthma, but perhaps you've received normal spirometry results when you tested the patient. We now do what's called a methacholine challenge test. Methacholine as a muscarinic agonist is going to be a potent bronchoconstrictor. That bronchoconstricting effect can help you to diagnose their bronchial hyperreactivity. Then we have the drugs pilocarpine and cevimeline. Both can be used for xerostomia, dry mouth, because these drugs can actually increase salivation. This shows up often on an exam in a patient with Sjogren's syndrome. It's an autoimmune disease. You get lymphocytic infiltration of the lacrimal and salivary glands, and oftentimes these are female patients in their late 30s, early 40s. If you had to describe a patient with Sjogren's syndrome with one word, I would have to say that word would be dry. They've got dry eyes, they've got dry mouth. Because it's common in women, vaginal dryness is another part of that scenario. We want to give them a muscarinic agonist to increase fluid production. Of course, be aware, many times you get a test question where they describe the scenario. You're asked basically to make a diagnosis, Sjogren's syndrome. You're then asked to think about what a treatment option would be, perhaps pilocarpine. But isn't it common that questions will often go on to tell you what drug you're going to use? You thought that was going to be the question, and instead they go on to say, so you have decided to give this patient the drug pilocarpine. That's very frustrating. The question goes on to say, which of the following side effects should the patient be monitored for while taking this medication? Well, that's easy if you just think about all of the different properties that we've reviewed for a muscarinic agonist. For example, this patient might experience diarrhea or excessive urination due to the GI and urinary stimulating effects of muscarinic agonists. The other use for pilocarpine is glaucoma. Formerly, this was an important use for this drug. Today, we have a lot of other glaucoma medications that we actually prefer over pilocarpine, but that's still an indication for this drug. This table looks at our acetylcholinesterase inhibitors. For your step 1 exam, this is a very, very important list of drugs. Many different uses for these drugs, many different properties that we have to be aware of. Let's start with edrophonium. Edrophonium is a short-acting drug used as a diagnostic for myasthenia gravis. Myasthenia is a very popular condition to show up on your step 1 exam. If you want to diagnose the patient, you can give them edrophonium. This is a drug that's going to increase the levels of acetylcholine. The patient gets a return of their muscle strength, and that can assist you in diagnosing this condition. Then if you'll notice, we have several stigmines in this table. In fact, the ending stigmine is very important to remember. If I ever see that ending on a drug name, I know that is an acetylcholinesterase inhibitor. But physostigmine is separated from neo and pyridostigmine in the table because physostigmine is a tertiary amine. A little bit of chemistry here. Physostigmine as a tertiary amine, those types of drugs are very, very lipid soluble. So this drug can enter the CNS effectively. Whereas neostigmine and pyridostigmine are quaternary amines. That means they have an extra hydrogen in their structure, giving them a positive charge. These drugs are very water soluble. They don't enter the CNS. So there's the difference between those three drugs. Physostigmine is most commonly used as an antidote in atropine overdose. If I reminded you that atropine, the prototype of the muscarinic blockers, is also a tertiary amine. Atropine can go into the CNS, and obviously atropine can work in the periphery. Don't you need an antidote that can stop both the central and the peripheral effects of this drug? Absolutely, and that's what physostigmine can do. Neostigmine and pyridostigmine would not be as effective as an antidote for atropine overdose because they're only going to stop the peripheral effects. So when I think about using these drugs, it is just for their peripheral benefit. The first two indications, ileus and urinary retention, to me are more common to treat with bethanechol. And the reason I would think of bethanechol first is it's a muscarinic selective drug, whereas acetylcholinesterase inhibitors, by raising the levels of acetylcholine, would have not only muscarinic effects, but also nicotinic effects. So a greater potential for side effects for using these two drugs. So what would I focus on for using neo and pyridostigmine? the treatment of myasthenia gravis. I want to treat myasthenia by increasing the levels of acetylcholine, stimulating the skeletal muscle to contract. I use these drugs as treatment because they have a longer half-life compared to edrophonium, the very short-acting drug used as a diagnostic. I can also use neo and pyridostigmine to reverse non-depolarizing neuromuscular blockers. If I think about those types of drugs, you think about drugs like atracurium, mivacurium, pancuronium, vecuronium, those non-depolarizing neuromuscular blockers. What does myasthenia and non-depolarizing neuromuscular blockers, what do those things have in common? They both involve the same receptor. In fact, if I said, what are the antibodies targeting in myasthenia gravis? You would say they would be targeting nicotinic N sub M receptors found at the neuromuscular junction. That's exactly right. What do non-depolarizing neuromuscular blockers target? What type of receptor do those drugs block? They also block the N sub M receptor. So that's what we're dealing with. We're dealing with two conditions that involve N sub M receptors. In both cases, if we raise the levels of acetylcholine, we can have some therapeutic benefit. In fact, let's explore that myasthenia patient a little bit more, because this is such a very common condition on the test. The patient is going to present with muscle weakness. Obviously, that can be weakness in muscles in general, but drooping of the eyelid, ptosis. You can also see difficulty in chewing and talking and swallowing. Those are all part of the patient presentation. The more the patient exerts themselves, the weaker they get. So the symptoms improve with rest. If you did a comparison between myasthenia and Lambert-Eaton syndrome, what is the difference in those two patients? I mean, what happens with a Lambert-Eaton patient when they exert themselves? That's right, their symptoms improve. What is it that the antibodies in Lambert-Eaton are actually targeting? Because it's not N sub M receptors, it's calcium channels. That's correct. So with continued exertion, the patient with Lambert-Eaton accumulates enough calcium to get muscle contraction. So they get better upon exertion. Always a good thing to stop and do a side-by-side comparison of similar conditions whenever you can. We move on now and discuss the drugs donepezil and rivastigmine. These are two lipid-soluble drugs that are both used in the treatment of Alzheimer's disease. There's a clinical correlate in the margin that we will discuss in just a moment related to this condition. We'll talk about exactly why an acetylcholinesterase inhibitor would be beneficial for this condition. Finally, we've got organophosphates. Now, this is a very special group of drugs, and here's what you should note. These drugs are irreversible inhibitors. You see, all other acetylcholinesterase inhibitors in this table, they're reversible. They're less dangerous compared to these irreversible organophosphates. It's the irreversibility of this drug that means we perhaps need to consider multiple antidotes for a patient who's been exposed to this type of drug. We see organophosphates used as insecticides. So malathion and parathion would be examples. And insecticide poisoning is a very popular question on the test. If you see that question that starts off discussing a 37-year-old farmer, perhaps you're considering insecticide poisoning as a possible scenario there. You also have to think about nerve gases. Sarin or VX nerve gases could also be a test question. These are irreversible inhibitors of acetylcholinesterase. They're obviously going to have pretty significant and possibly fatal effects on a person who gets exposed. Again, this makes for a very good test question. In the margin is a note about Alzheimer's disease. Again, characterized by late onset dementia, progressive memory loss, and cognitive decline. You know, many people when they discuss Alzheimer's disease, they remember the neurofibrillary tangles, the amyloid plaques. But what I want you to consider is what is the rationale behind using acetylcholinesterase inhibitors to treat this disease. Remember, it's because of loss of cholinergic nerves in Meinert's nucleus. Another way to say that is patients with Alzheimer's have less acetylcholine. When we use an acetylcholinesterase inhibitor, we can increase the levels of that transmitter and have some benefit in the treatment of Alzheimer's. There's an easy way to remember the side effects caused by acetylcholinesterase inhibitor poisoning, especially if you're thinking about organophosphates. That overdose, that exposure type situation, very popular on the exam. The mnemonic that we use to remember these side effects is dumbbells. That's right. It's a mnemonic that you have to practice spelling, by the way, because dumbbells, the second part of that, is not spelled how you would normally think. In fact, if you were to take the word bells and double every letter that's not supposed to be normally doubled, you could actually come up with 2 B's, 2 E's, 1 L, and 2 S's. When I look at the different parts of dumbbells and I identify what's going to happen, like diarrhea, your challenge should be to indicate exactly what receptor mediates each symptom. If I think about what receptor causes diarrhea, for example, that would be overstimulation of, that's right, muscarinic M3 receptors. What about urination? That's also M3. Meiosis, pupil constriction, that's M3. Bronchoconstriction. On the lungs, you also have M3 receptors. Okay, be careful. What about bradycardia? That's right, the heart has M2, so that would be M2 activation causing bradycardia. Emesis, the fact that you can get some nausea and vomiting with acetylcholinesterase inhibitor poisoning, perhaps that's related to M1 receptors in the CNS. Now, excitation, we're going to skip that one just for a moment. Come back, we'll focus on that in just a moment. We'll come back to that. Lacrimation. Lacrimation is M3. Salivation, that's overstimulation of M3 receptors. And sweating. Sweating is also caused by muscarinic receptors, and those receptors are M3s. Isn't it true that most of dumbbells is M3 mediated? Exceptions up to this point have been bradycardia, that's M2, emesis, M1. But let's focus on excitation, especially excitation of skeletal muscle. Now, what receptor is that? If it's skeletal muscle, that's N sub M. That's the receptor at the neuromuscular junction being overactivated. If I said excitation of the CNS, can you identify 2 receptors that might be involved in that action? The muscarinic receptor that would be involved in excitation of the CNS would be M1. But what about the nicotinic receptor? That's right, N sub N. So excitation is a little bit more complex because it involves, many cases it involves nicotinic receptors, but also could involve muscarinic receptors. When I think about insecticides, remember that these are long-acting, irreversible inhibitors. They can be subcategorized as carbamates or organophosphates, used in agriculture, drugs like malathion and parathion. We have a diagram that shows you why these are more selectively toxic to insects compared to humans. For example, parathion and malathion are actually prodrugs. They have to be activated by P450 enzymes. That happens very quickly in insects, but very slowly in us. So the insects rapidly convert these drugs into their active form. And then there are other P450 enzymes that inactivate this active form. That happens very quickly in us, but very slowly in insects. And so what that means is the active ingredient of these insecticides accumulates in the insect and is less likely to be formed in us. With all that being said, however, if you have a person who gets exposed to a large quantity of an insecticide, it almost doesn't matter how quickly their P450 enzymes work, that person is going to be at risk for developing dumbbells. Your book has a very nice summary of the toxicity of acetylcholinesterase inhibitors. We have previously summarized by using the mnemonic dumbbells all of the different muscarinic effects and the different nicotinic effects. It's very important to understand the management of acute acetylcholinesterase inhibitor toxicity. Since we've identified using the mnemonic dumbbells that most of the side effects of acetylcholinesterase inhibitors were caused by overactivation of muscarinic receptors. You can imagine that a muscarinic antagonist like atropine would be very important. Atropine does a great job of relieving the symptoms associated with dumbbells. But if I were to ask you to think about what part of dumbbells atropine would not be able to reverse, what would you say to that? Muscarinic blockers can't reverse any of the nicotinic effects caused by an acetylcholinesterase inhibitor. Importantly, that would include skeletal muscle excitation. In fact, if I said, what part of dumbbells is most often going to be fatal? It's interesting because a lot of people would look at the B's. They would look at bronchoconstriction and bradycardia and be very concerned about those. And obviously you should be. But what's more likely to be fatal is the E. It's the excitation of skeletal muscle. And this is what this note reminds us of. It's permanent depolarization of the diaphragm, kind of an important muscle. You inhibit breathing and cause death. Because what happens is you are continually activating nicotinic receptors, N sub M receptors on the diaphragm. Eventually those receptors become desensitized and they stop responding. You paralyze the diaphragm, and that's what causes death. Atropine is not going to be able to stop that effect because it's nicotinic mediated. In that case, we can use a second antidote, a drug called pralidoxime. Pralidoxime is often abbreviated as 2-PAM. It's what's referred to as a regenerator. If you think about that term, it can regenerate acetylcholinesterase. The reason this drug can do this, do you remember how acetylcholinesterase inhibitors that we call organophosphates actually bind to the enzyme? They are irreversible inhibitors. They form very strong covalent bonds with the enzyme. Pralidoxime has the special property of being able to break that bond. It can break the bond between that nerve gas or insecticide and acetylcholinesterase. When you break the bond, you remove the poison, if you will, from the enzyme, and now acetylcholinesterase works. It has been regenerated. Once acetylcholinesterase can work once again, it starts to break down acetylcholine. When the levels decrease, including at the neuromuscular junction, you get the relief of all of the effects associated with dumbbells. Of course, there is a very critical component related to the timing of using a drug like pralidoxime, and that is because you can get time-dependent aging of your nerve gas or insecticide. Aging, sometimes referred to as chemical aging, is a process whereby the organophosphate changes its structure to such an extent that pralidoxime will no longer work. That timing sometimes can even be minutes with certain nerve gases. For drugs, it's often many, many hours before aging takes place. Here's our figure that looks at the effects of acetylcholinesterase inhibitors and how we can use pralidoxime as an effective antidote. On the left, you see the drug indicated as P, that's your organophosphate. Notice that the R sticking off of that is your leaving group. That is your functional group that is going to be removed in a process that we call aging. When you get right down to it, aging is really a hydrolysis reaction that removes that functional group. You must give pralidoxime before that happens. Give pralidoxime before aging takes place, and pralidoxime can effectively remove the organophosphate from acetylcholinesterase, thereby regenerating the enzyme. That's the reason why, if you've got a scenario, let's say you get someone exposed to a nerve gas that's an acetylcholinesterase inhibitor, you want to rapidly use your antidotes, atropine and perhaps also pralidoxime, in order to quickly antidote this situation before aging takes place. There is a risk of chronic toxicity with acetylcholinesterase inhibitors. Patient can get some peripheral neuropathy, causing muscle weakness and sensory loss. There's possibly also demyelination that's not due to acetylcholinesterase inhibition. But when it comes to your step 1 exam, it's the acute effects of these drugs that are way more important than the chronic toxicity.